Hello, everyone. We're going to be allowing just a few more minutes just to allow more providers to join in the training before we get started. Okay. All right, welcome everyone to the 2022 Medicaid Statewide Provider Training for the Medicaid Pharmacy Program. My name is Dana Boyd. I'm a certified pharmacy technician, and we have other members of our pharmacy team, as well as managed care and healthcare policy joined in the meeting as well. Thank you for joining us. Just a few housekeeping items before we get started. We do ask that you have your cameras turned off and your microphones on mute. This presentation will be recorded and posted on our website along with the slides. And if you do have any questions, we will be holding that at the end of the presentation, and you can utilize the chat, and we'll make sure that your questions get answered. And if we can't get those to you today, we'll grab your contact information to get those answered. So our agenda for today is to go over the pharmacy overview, navigation, billing, opioids, retro GUR and MTM services, prior authorizations, and a quick quiz. So I hope you'll be paying attention. And then before we get started, we do want to take a few minutes to go over the state agency consolidation. During the 2021 legislative session, the House Bill 365 state agency realignment consolidated the two primary social service agencies, the Utah Department of Health and Department of Human Services, into one agency as of July 1st of 2022. And the Department of Health and Human Services, or DHHS, is designed by the Centers for Medicare and Medicaid Services. The Division of Integrated Healthcare, DIH, is within DHHS and is responsible for implementing, organizing, and maintaining the Medicaid program and the Children's Health Insurance Program. If you have any questions or would like more information, you can go to the Utah DHHS plan website. Managed care. Managed care is a healthcare delivery system organized to manage cost, utilization, and quality. Medicaid and CHIP managed care provides for the delivery of health benefits and additional services through contracted arrangements between the department and managed care entities. And these are the managed care programs and CHIP managed care programs listed. Here's a list of our managed care entities, as well as a table of prepaid mental health plans, contact information, and area. We do have managed care team members joined in the meeting, so if you have any questions, feel free to put them in the chat. Pharmacy policy and coverage. So the pharmacy program is part of the Office of Healthcare Policy and Authorization. We have an absolute amazing team consisting of clinical pharmacists, technicians, and consultants. Our team works really hard to ensure safe, appropriate, and cost-efficient use of medications through determining pharmacy program coverage, prior authorization determinations, and creating policy for Utah's Medicaid population. In this next section, we're going to be going over how to navigate as well as find helpful resources for the MIBS and manual, rule, state plan, DUR board, and PNT committee. This is our pharmacy program website where most, if not all, of our resources are housed. We do encourage you to visit and familiarize yourself with our website to find out more information regarding the Utah Medicaid Pharmacy Program. So we'll be showing you how to navigate to some of these resources. Feel free to navigate with us. That might be a little bit easier. Our Medicaid information bulletins, or MIBs, and manual are updated bi-monthly, and changes are announced through the Medicaid information bulletins. To navigate to the MIBs and manuals, you'll need to go to our website at medicaid.utah.gov. There's a tab at the top for providers that you'll click on, and then Medicaid Pharmacy Program, Resource Library, Learn More, and you can find the link to the provider manuals and MIBs under the link, quote, other helpful information can be found on the following pages, end quote section. And then from there, that's where you can click on the most recent manual or previous manuals or MIBs you like to review. You can also sign up for the Utah Medicaid newsletter and also receive email notifications of policy changes and MIBs here as well. The Utah Administrative Code or rule are legally binding policies defined, implemented, and overseen by the agency responsible. The pharmacy manual represents available services and policies that are designed to be used in conjunction with federal regulations and sections of the rule, which is R 414-60 Medicaid Policy for Pharmacy Program. And to navigate to the rule, you'll need to go to the Utah Office of Administrative Rules website, type in a word or phrase in the search bar for current rules. The Medicaid Pharmacy Program is, like I mentioned, R 414-60. You will need to put in a capital R or else it won't pull up any results. The DUR and PNT committee, as well as other specific information related to pharmacy program, may also be found on the Utah Medicaid Pharmacy website. And now I'm going to be turning the time over to our clinical pharmacist, Brian S. Larson, to go over more information on the DUR and PNT and the state plan.
Thank you, Dana. Let's start with the DUR board. The Drug Utilization Review Board, or DUR board, is an advisory board to the division established to ensure that the use of prescription and over-the-counter drugs are appropriate, medically necessary, and are not likely to result in adverse medical results. For example, the DUR board makes recommendations around prior authorization criteria, quantity limits, things like that. The Pharmacy and Therapeutics Committee, or P&T Committee, is a subcommittee of the DUR board and is established to advise the division on the safety and efficacy of classes of drugs on the preferred drug list, or PDL. And the DUR board is composed primarily of physicians and pharmacists with one position for a dentist, as well as a consumer representative who's not a healthcare professional. And the P&T committee is composed of pharmacists and physicians. The Utah State Plan is a governing document that describes how the state administers its Medicaid program. Every state Medicaid program in the country has a state plan, which is approved by CMS at the federal level. And it includes information about many things around the governance of the Medicaid program. And pertaining to pharmacy policy, we have information about reimbursement methodology, dispensing fees, 340B policy, and covered OTC classes. Some important attachments to the state plan that include information that's relevant to pharmacy policy include attachment 3.1A and 4.19B.
Thanks so much, Brian, for that. In this next section, we're going to be going over Medicaid pharmacy program billing information for VFC admin and vaccine codes with SL modifier, pharmacist prescribing updates, compounds, 340B review, DAW, and early refill policy. The Vaccines for Children, or VFC, are vaccine administration codes that must be billed with an SL modifier, and total number of units must be billed to match the total valid vaccines. The next few codes, 90471, includes percutaneous, intradermal, subcutaneous, or intramuscular injections for one vaccine, and you only bill it as one unit. It cannot be billed in conjunction with 90473, which is intranasal or oral, and you cannot bill oral vaccine for this administration. 90472, similar to 90471, but it's for each additional vaccine, single or combination vaccine or toxoid. They have to be listed separately in addition to code for primary procedure and cannot bill as an oral vaccine. For 90473, you have to bill this as an oral vaccine as one unit, can only be billed alone or in conjunction with 90472, and as previously mentioned, cannot be billed in conjunction with 90471 or 90474. 90474 is for intranasal and oral route. For each additional vaccine, list separately in addition to code for primary procedure, must be billed as one unit and as an oral vaccine as well. And now I'll turn the time over to our clinical pharmacist, Luis Marino, to go over pharmacist prescribing updates.
Thanks, Dana. So for this slide, please refer to the January 2022 MIB, which describes pharmacist prescribing. And effective January 1st, 2022, a pharmacist may prescribe a prescription drug or device for specific conditions without the oversight of a physician. These conditions are determined to be public health concerns by the Department of Health in accordance with Utah Code 358-17B-102. These conditions include, but are not limited to, HIV prophylaxis, post-exposure and pre-exposure, self-administered hormonal contraceptives, smoking cessation, and naloxone. Also, effective January 1st, 2022, Utah Medicaid will pay a dispensing fee for any prescriptions dispensed with a Medicaid registered pharmacist individual NPI. Pharmacists who wish to prescribe for Medicaid members will find more information on how to become a Medicaid provider at the link provided. So please, pharmacists must be enrolled as a provider with Medicaid in order to take full advantage of this opportunity. And I'll turn it back to Dana.
Thanks, Luis, for that. On this next one, we have sent out a compounding fax blast to provide instructional steps and tips on compound billing based on NCPDP standards to ensure accuracy of pharmacy compound claim submission. So we'll be going over some compound billing through the pharmacy point of sale and some tips that you can use. So all compound claims for Utah Medicaid fee-for-service members must be submitted using the NCPDP version, D.0 standard multi-ingredient compound functionality. Therefore, all ingredients must be entered with the correct quantity and cost for each ingredient included. All prescriptions that are compounded must be submitted as a compound claim. And to ensure the accuracy of Utah Medicaid fee-for-service members' profile, all prescriptions, including compounds, must be submitted to Medicaid fee-for-service for adjudication, and pharmacy lack of understanding of compound claim billing must not result in the members being required to pay for their compounded prescriptions or payment being waived without claim submission. So it's important that each pharmacy staff member who bills Utah Medicaid fee-for-service become fully educated on the proper billing of compound claims. And if you're having difficulty billing a compound and you're receiving a reject code such as 20-M/I compound segment, that just suggests that the 11 digit NDC number is not being populated correctly. So please contact your software vendor to verify that your system is set up to bill multi-ingredient compounds. So here we have a compound example for 22 omeprazole capsules compounded with 100 mLs of sodium bicarb, injection 8.4%, and 50 mLs of cherry syrup. We have seen many claims submitted where the pharmacy staff selects a recipe that is already entered into the pharmacy point of sale system, and the ingredients in the initial recipe and the prescription being dispensed are the same, but the quantities in the initial recipe differ from the compound quantities being dispensed. And this may result in claims that convert the individual ingredient quantities to a percentage of the quantity from the initial recipe, such as quantities of tablets, etc., are being billed. For example, in this one, it would be 24.567 capsules. Therefore, we recommend that each time a compound is dispensed with a new recipe, be entered. If the quantities differ at all, then it needs to be entered correctly and not being billed for quantities different than what is being dispensed. When calculating the total quantity that's filled 442-E7 of the entire compound, please enter the sum of the individual ingredients that significantly contribute to the end volume or weight of the completed prescription. However, do not include the quantity of tablets or capsules. In this particular example, 22 capsules of omeprazole in 100 mLs of sodium bicarbonate and 50 mLs of cherry syrup would have a total quantity of 150 mLs, not 172 mLs. And you can see the top part is where it's filled incorrectly, and then the bottom part is the corrected claim. So you can refer to the compounding facts blast for more detailed information, including some other examples of correct and incorrect billing of compound claims. Pharmacy POS 340B review. So 340B claims must be submitted with the provider's 340B acquisition cost in the ingredient cost field, a value of 8 in the basis of cost field, and 20 in submission clarification code. If these values are not entered, it just indicates that it was purchased outside of the 340B program, and Utah Medicaid will pursue the federal Medicaid drug rebate and supplemental rebate on those claims. For medical claims 340B review, all claims must be submitted to Utah Medicaid from a 340B covered entity. For medications that were purchased through 340B program, they have to have the UD modifier after the HICS code on each claim line. And for Medicare crossover claims, the TB or JG modifier needs to be submitted. JG are drugs or biologicals that acquired with 340B drug pricing program discount, and TB is drug or biological acquired with 340B drug pricing program discount reported for informational purposes. And claims without these modifiers will just indicate that it was purchased outside of the 340B program. Dispense as written for non-preferred psychotropic products. Pursuant to House Bill 437 that was passed during the 2016 general session, Utah Medicaid has begun placing psychotropic drugs on the preferred drug list effective July 1st of 2016. And for the purposes of the preferred drug list, psychotropic medications are defined as atypical antipsychotics, antidepressants, anticonvulsants or mood stabilizers, anti-anxiety medications, and attention deficit hyperactivity disorder stimulants. The first class will be placed on the PDL in July will be the ADHD stimulants, with other classes being added in subsequent quarters. And just a note that in accordance with UCA 58-17B 606 4 and 5, the DAW code will not allow claims for the brand name version of a multi-source drug to bypass the prior authorization requirement, even if the brand name version of the drug is listed as non-preferred, and the prescriber writes dispense as written on the prescription. So an exception to this case would be that if that brand name drug is listed on the brand over generic reference. And in that case, the DAW code will only override the brand name drug. In order for a prescription to be eligible for the pharmacy to submit the DAW code of 1 to bypass the edit for non-preferred medication, the prescriber must write out dispensed as written on the physical prescription. Check boxes or pre-printed forms that include dispense as written are not acceptable substitutes for the prescriber writing dispense as written on the prescription. For electronic prescriptions, they must state dispense as written as either a note or as part of the prescription drug order to satisfy this requirement. Verbal orders that include dispense as written must be reduced to writing on the prescription by the pharmacist accepting the verbal order and documented in the member's medical record. And now I'll turn the time over to Joe to talk about early refill policy.
Thanks, Dana. So this is a change since we had last year's training. We've changed our early refill policy. Previously, it was we were limited to granting overrides for early refills based only on life-saving situations. But effective November 1 of 2021, that was changed, and now the pharmacy team will adjudicate requests for early refill requests that come through the system against medical necessity. And that's defined in some of the references that are provided there on the slide if you have any questions. But I think the take-home message here is that that's a change. If you as a provider feel like you've got a situation where an early refill should be implemented and it's medically necessary, we ask that you contact us, you call in, and we can review that particular situation. Again, for more information, the listing is Dana's got the November 2021 MIB or Medicaid information bulletin listed there.
Thanks, Joe. So we will turn the time back to Joe again to go over some opioid updates and interventions. Take it away.
So hopefully everyone on the call at least is somewhat familiar with the actions that Utah Medicaid and a number of other payers have taken relative to opioids. And those actions have been implemented over the last couple of years, all in alignment with the CDC guideline for the use of opioids in chronic pain. So those included things like the request for concomitant opioids and benzos that's restricted or requires a prior authorization. We need a prior authorization if you don't use a short-acting opioid for a long-acting opioid. In alignment with the CDC guidelines, we ask that patients receive a 7-day initial script or 3-day from dentists initial prescription before they receive longer prescriptions. We have a morphine milligram equivalent of 90, and for members that don't have cancer, that is. And if the request exceeds that, we ask that a prior authorization be submitted. Finally, there's some very select members that, again, in alignment with the CDC guidelines, prior authorizations are required. So children under the age of 18, pregnant members, and members who are receiving opioid use disorder meds in addition to opioids, those require prioritization. The change, just effective a couple of months ago, we tweaked our quantity limits on some of the short-acting opioids to more match community standards of care. So, 1 to 2 Q, 4 to 6 hours. I think you're going to find that those, in many cases now, won't require a prior authorization as long as the overall opioid load or total opioid that the patient is receiving does not exceed an MME of 90. So again, we've changed a selected number of those short-acting opioids quantity limits. We have been implementing this over a couple of years. I mean, I realize this is a bit of a complex slide here, but what we've done is taken on the left axis, or on the vertical axis, is the number of patients, and this is stratified into 5 different cohorts, or in this slide, 4 different cohorts. So the gold group, number 5 over there on the right, those are patients at MME levels of over 180. We had 16 of those members when we started educational programs with both the providers, and we now have, in many months we have none, some months we have 1. But overall, as you can see, so that group 4, which is a little bit lower MME values, 150, 179, all the way down to group 2, which is MMEs of 90 to 120, which is the blue or top line, you'll see an overall tendency of fewer members receiving these high doses of opioids that are not recommended by CDC or other treatment guidelines. It's been effective, but if you've got a patient for whom higher doses of opioids seems appropriate, we have a prioritization process for that, and welcome reviewing each of the situations individually.
Thanks so much, Joe. We'll turn the time over to Luis to go over our naloxone prescribing.
Thank you, Dana. Along with what Joe was saying regarding aligning with the CDC guideline for safe opioid prescribing, we also encourage naloxone prescribing. And the CDC emphasizes the importance of prescribing naloxone in the following scenarios, which have been shown to increase the risk of an opioid overdose. These include patients with history of overdose, patients with history of substance use disorder, prescribed MME greater than or equal to 50, patient is taking opioids concurrently with benzodiazepines, patients with sleep disorder breathing, patients at risk of returning to a high dose to which they have lost tolerance. And we also continue to encourage providers to check the controlled substance database to monitor for the following total MMEs, including opioid prescriptions from other healthcare providers, monitoring for the other controlled medications that the patient is being prescribed, including benzos, monitoring for the length of treatment with opioids and other controlled medications, and consider opportunities for tapering off if clinically appropriate. Utah Medicaid covers most naloxone products, including generic injections or sprays, as well as brand name products for naloxone. And so now we'll turn the time over to Dana.
Thanks, Luis. In this next section, we're going to be going over what is retro DOR and MTM services. So what is it? It's when the pharmacy staff utilizes communication tools such as motivational interviewing to promote and reinforce best practices in the delivery and administration of pharmacy benefits. Retrospective drug utilization interventions are often determined through a review of claims data or other records. Outcome measures are often derived from CMS guidance, as well as measures outlined by the National Committee for Quality Assurance to utilize claims data to create interventions or improve member outcomes. So we'll be briefly going over hemophilia case management, antidepressant medication management, hepatitis C adherence program, antipsychotics in children, and ADHD stimulants. And I'll turn the time over to Luis.
Okay, so for MTM, this opportunity to provide MTM services is available to eligible pharmacists in the outpatient pharmacy or clinic setting. So that includes community retail pharmacists and ambulatory care pharmacists who are enrolled as providers with Utah Medicaid. Eligible members must be enrolled as Utah Medicaid beneficiaries, which includes children and adults who are taking at least 3 medications, who have at least one chronic condition. The following members are not eligible for MTM services: members who are inpatient or in a long-term care facility, members who are eligible for Medicare Part D. And for more information about the MTM program, please visit the official MTM webpage at the link provided. Back to you, Dana.
Thanks so much. For hemophilia case management, fee-for-service members and their families receive comprehensive care management services provided by a multidisciplinary team of healthcare professionals from the hemophilia treatment centers and Utah Medicaid pharmacy team per the national treatment guidelines. Care management includes, but is not limited to, claims review, verification of monthly eligibility and ongoing enrollment requirements, contact with eligible fee-for-service Medicaid members to assess their hemophilia needs and well-being, continuous outreach to ensure adherence and transparency of care, and coordinating with in-home nursing and the HTC as necessary. The members of the care team from the Utah Medicaid Pharmacy include clinical pharmacists and pharmacy technicians that have received comprehensive training from the hemophilia treatment centers, as well as online training. And with that, I'll turn the time over to Joe for antipsychotics in children and ADHD pharmacy edits.
So for background, antipsychotics in children is a very high priority item to the federal government via the CHIP and CMS program. It's also a priority for us as a Medicaid pharmacy program to make sure that the children receive mental health medications that are appropriate for them and their situations and in alignment with guidelines. So as Dan and Luis mentioned on a number of other disease states in alignment with things like the American Association of Child and Adolescent Psychiatrists or the American Psychiatric Association, we put in place a number of utilization tools to help ensure that these kids get the right medications. A change is the one at the first. Previously we required a prioritization for members under the age of 20 if there were multiple concurrent use of antipsychotics. That has been changed now to required for members that are under the age of 18. But all of the other utilization management tools we've had for some time continue to remain in place, and those include, diagnosis code is needed. We sometimes get questions about that from pharmacies. You should get that from the provider and enter that in the claim. Initial prescription, so as it says below there, we ask for prioritization in very young children under the age of 6 because there's no guideline that recommends the use of these meds in children that young, or doses that exceed either the package insert or a number of nationally recognized compendia. If the dose exceeds that, we ask for prioritization. Again, concurrent multiple antipsychotics, that requires a prioritization. And last, but certainly not least, long-acting injectable antipsychotics are sometimes requested in children or for children. So we ask for prioritization because none of them are indicated in that particular use. Also, in alignment with all of the treatment guidelines and the manufacturer package inserts, etc., all of them recommend that these patients also be monitored for antipsychotic side effects. So there are metabolic side effects to the antipsychotic drugs, and that includes dyslipidemia and abnormalities in glucose. So we ask that testing for those two lab values to be done, and for a patient to be routinely assessed for movement disorders, and pick your favorite movement disorder scale to use for that. And then, as I mentioned before, we require diagnosis code for antipsychotic prescriptions for kids. For attention deficit, this is a more recent series of utilization management we put in place. Again, all in alignment with recognized standards of care, the American Association of Child Adolescent Psychiatry, package inserts, other compendia on the use of ADHD meds in kids. So none of the meds have an indication for kids under the age of 4. So we require a prioritization if that's the situation, except for selected meds don't have an indication for children under the age of 6. So Adenzys, Dianavel, Desoxyn, and Adhanza have that little bit higher age limit. We require prioritization if multiple agents are being used. And we sometimes get questions, well, I'm going to use a 20 milligram in the morning and a 5 milligram in the afternoon. Well, that's fine, but it's if you have 3 different ADHD stimulants, then that's going to require prioritization. There's a cross-class edit, so none of the guidelines recommend use of meds from the amphetamine class and the methylphenidate class. If the provider feels like that's appropriate, then we'll need a prioritization for that. We have implemented a number of educational outreaches to the prescribers of at least, the folks that see a lot of these kids, and it's been very, very positive to the feedback from those providers. So that's good. We join in wanting to make sure these kids get, again, appropriate meds at the appropriate dose, appropriate time. We have a prioritization form specific for this situation. Dana?
Thanks, Joe. For the hepatitis C adherence program, we do have this started April of 2020 for our fee-for-service members, aimed at increasing treatment completion rates and cure of hepatitis C infection. We know that adherence to hepatitis C is really essential for ensuring a treatment cure for undetectable viral loads. And our pharmacy staff reaches out to our members who have been enrolled in the program and follow up with them. Also with those who have been non-adherent to their hep C medications during the course of therapy. And we do provider outreaches for provider support and also identify barriers to adherence. And follow-up is conducted throughout the remainder of the treatment therapy. And our overall adherence goal is 90%, and with interventions, since the program started, is 91% as compared to 80% without any interventions. Luis?
Thanks, Dana. So now I'll go over antidepressant adherence program. So this is a member-centric retrospective DUR intervention aimed at improving antidepressant medication adherence. And it is derived from the National Committee for Quality Assurance, or NCQA, antidepressant medication management, or AMM measure, to identify members with newly diagnosed depression. And the clinical pharmacist conducts phone calls to targeted Utah Medicaid fee-for-service members and uses motivational interviewing techniques to help identify barriers to adherence and address health literacy and create a strategy for change in these patients. The pharmacist may also assist the member in the following ways, such as ordering medication refills for the patient, calling the pharmacy to see if there's any available, finding a pharmacy that delivers medications to the patient to make it more easier, or connecting the member to a health program representative when the member has other needs. The pharmacist also contacts the member's mental health care provider to provide pertinent information, such as member-reported side effects to antidepressant, or refill request on behalf of the member. Follow-up calls are also conducted for continued medication adherence support for these patients. And now I'll turn the time over back to Dana.
This next section is for pharmacy prior authorizations. We'll be going over how to navigate the PDL, where to find pharmacy PA forms, PAs that are not required, the 72-hour medical emergency overrides, what to do when you receive a pharmacy PA denial, and a record keeping. And I'll turn the time over to Brian to present on the PDL.
Thank you. The preferred drug list is a list of drugs that are preferred or non-preferred. It is distinct and different from whether or not the drug is covered, but we have a list of preferred drugs and non-preferred drugs that the department has determined to be those we prefer to have used. For a drug that is non-preferred, if a provider wishes to use one of those drugs, we do have a prior authorization that's required, and usually it requires the trial and failure of a preferred drug. The prior authorization forms are reviewed by clinical staff, and we have the current preferred drug list incorporates what used to be several different references, including the preferred drug list, the drug criteria limits document, which would be like quantity limits, things like that, the brand over generic list, the list of covered over-the-counter drugs, our mandatory 3-month supply list, and a list of prior authorization forms. For the prior authorization forms that we have, there's many of them. Each of these forms is reviewed at least annually by our clinical staff. In some cases, as it's warranted, if new guidelines or other information, we may review some forms more often than that. An example would be if a drug class gets reviewed in the DUR board or P&T committee before the annual date, or if there's new guidelines. We also have diagnostic products on the PDL. This includes diabetic supplies such as diabetic test strips, lancets, and continuous blood glucose monitoring products. These products, for non-preferred products on the PDL of diagnostic products, they must be billed through the medical benefit as DME, and there's a DME PA form on our website as well. For additional information, we have links to the preferred drug list and the medical supplies and durable medical equipment manual. When navigating the preferred drug list, it is a large document, currently over 100 pages. The easiest way to find what you're looking for is Control F or Command F if you're using a Mac, and typing in the word you're looking for, whether it's the drug name or a drug class, and that's the best way to navigate to find what information you're looking for on the preferred drug list. And I'll turn it back to Dana.
And so we receive quite a few of prior authorizations that doesn't actually require prior authorization. So we hope that this will be helpful to you. The following do not require PA: diagnosis codes for initial antipsychotic prescriptions. So the billing pharmacy must submit the valid ICD-10 diagnosis code that's provided by the provider on the claim, and that should pay if it's within the policy limits and guidelines. For DOR rejects, the DOR interventions, such as for short-acting opioids and benzo, DOR edits, or concurrent, for DOR edits and short-acting opioids before long-acting opioids. Those interventions just need to be entered with the valid DOR intervention codes on the claim. And if you don't know what those are, you can reach out to the customer service line as well at 801-538-6155. The G89.3, which is neoplasm-related pain for acute and chronic, that's related to cancer pain, they have to be submitted with the ICD-10 diagnosis code of G89.3 to bypass any of the quantities and/or MME limits. The 3-month supply required, and the PDL has a select list of maintenance medications that require a 3-month supply of the medication. Prior authorization will not be required when the script is written or billed for the 3-month supply on the claim. And for more information, you can refer to the preferred drug list and resource document. We have a 24-hour turnaround time within business hours in accordance with Utah Code 26-18-105. When a medical emergency occurs for a medication that requires a prior authorization, the pharmacy provider may dispense up to a 72-hour supply of the medication without obtaining a prior authorization. The pharmacy must submit prior authorization type code of 461-EU equals a 2, and prior authorization number submitted 462-EV of 72. And the 72-hour override is limited to 2 per month per NDC per member. All copay and dispensing fee rules apply, and details can be found on the PA Forms website as well, and the link is provided. For PRISM information, the pharmacy prior authorizations will not be affected by PRISM, so providers can continue the same process for submitting prior authorizations as before via fax. If you have any questions about PRISM, you can get e-learning training materials on the link provided on the slide or visit the PRISM website for more information. Okay, what do you do when you receive a denial from Utah Medicaid? First, you have to review the denial reasons that will be provided on the letter, and you can give us a call if you have any questions on the denial reasons or need further clarification. We would be happy to go through them with you. If the request was denied for a product that is non-preferred on the PDL and a preferred product has not been tried, consider switching to a preferred product. Most of our preferred products do not require a prior authorization. If the request was denied due to lack of information regarding clinical criteria, just resubmit the request with the needed information that supports criteria for approval. And if no additional information can be sent and no additional action can be taken to satisfy the criteria, you can submit a pre-hearing request with the Administrative Hearings Unit within 30 days, and the request form can be found at the link provided. Record keeping. Providers are required to maintain accurate clinical records and are subject to audits, which findings could result in recoupment of payment from the provider. It is the provider's responsibility to maintain accurate clinical records, including keeping progress notes applicable to the date of service, maintaining and updating each individual's plan of care, document specific types performed on date of service, document services billed, numbers of units billed, should support units documented, keep a record of physician's orders, submit record keeping documentation as requested by the department or under the direction of an audit. And you can refer to Section 1, General Information, Chapter 4 on the Utah Medicaid website for more additional information. And the moment that you're all waiting for is the quiz. If you know the answers, feel free to put them in the chat. But the first question is, where can you find pharmacy policy information? Number 2, what does the ICD-10 diagnosis code G89.3 allow the pharmacy point of sale system to bypass? Number 3, will a preferred medication listed on the PDL require a PA? And lastly, what is the preferred CGM and what PA form does it require? All right, and here are the answers. So we'll go through each one. The first one, where can you find pharmacy policy information? The pharmacy Medicaid pharmacy program website. Number 2, what does the ICD-10 diagnosis code G89.3 allow the pharmacy point of sale system to bypass? So G89.3 is for neoplasm-related pain. It bypasses quantity and/or MME limits for opioid claims, and all other policy limits apply. Number 3, will a preferred medication listed on the PDL require a PA? Answer is, it depends. Most of our preferred medications on the PDL do not require a PA, but some of them will be listed as preferred, but also require a PA. So you'll just need to double check the preferred drug list. And number 4, what is the preferred CGM and what PA form does it require? So this one just requires a little bit more research on your end. If you looked at the preferred drug list, you'll see that the Dexcom G6 products are preferred, but also a PA is required. The criteria on the continuous glucose monitors PA form is needed for approval. And that concludes the statewide provider training for the Medicaid pharmacy program. We can take any further questions you may have at this time. Any questions? It doesn't sound like it, so that probably means we did a good job. But if you
There was
do
one question that just came up in the chat.
Okay, perfect. Can I please get a contact that I can reach out to regarding IV therapy billing? Are you thinking of like HCPCS code for medical billing? Or if I can get your contact information, we can reach back out to you, or you can even reach out to our customer service number, 801-538-6155, option 3, option 3, option 2. Okay, perfect. So we will follow up with you with that. Thank you, Sharon. And then you can also reach out to us via email as well. Does anyone else have any questions? Okay, well, I just want to thank you all for your time and thank you so much for attending. We hope to see you at our next year's statewide provider training. Have a wonderful day.